Hi, everyone. My name is Christina Davis. I am the clinical pharmacist in the Cutaneous Oncology Clinic at University of Colorado, and I am very excited to be here today talking to you about management of oral chemotherapy agents. I feel like this is a very broad topic, and I feel like you could probably talk for days about different aspects of managing oral chemotherapy agents. Today, I'm going to try and hit a few of the highlights that come into practice a lot within our clinic that I hope will be beneficial for you as well. Start off just by going over some overview of oral oncolytics, the types of oral oncolytics that are out there, what you guys are probably seeing out in practice. Going over some dosing and administration sorts of things, as well as adherence. Adherence is a huge thing that has really become, specifically in oncology, very, very important in managing these patients. And as you guys all know, nurses are really the front lines of who's interacting with patients on a regular basis. So everyone really comes into play for this as well. Safe handling, storage, and disposal. I feel like this is something that probably doesn't come up as often as it should. So hopefully hit some highlights there and go over some things that maybe don't come up as much. Definitely have to talk about drug interactions anytime we're talking about oral oncolytics. So we'll go into that, as well as some access and reimbursement things. These are things that you probably won't be talking about as much with patients, but just good to kind of have background information on it if patients do ask you about certain things. One thing that I think is super, super, super important to talk about is contraception. So we'll talk a decent amount about that, as well as VTE. The reason why I chose VTE is really because, as we know, all patients with metastatic cancer are at a higher risk for VTE than the common population. And a lot of oral drugs also increase your risk or the patient's risk of having a clot. So we will talk about that as well. So just an overview of oral oncolytics. So I just tried to type out very broadly things that come up very commonly when talking about oral cancer treatment. So oral cancer treatment is often perceived as easier to tolerate than IV treatment because it's a pill that you can take home, so therefore it must be easier, which is definitely not the case. A lot of people also perceive oral cancer treatment as potentially being less effective because it's not being administered, intravenously, which also is not true. One really great thing about oral oncolytics is that they are much more convenient and obviously for ease of administration for a variety of different populations, such as people that maybe have travel restrictions, people that can't make it to the hospital as frequently, people that live really far away. So definitely better for those patients. Less frequent monitoring occurs. So as you know, because patients aren't coming in for their infusions, they really are monitored less frequently than those patients who are coming in for some sort of IV treatment. So education is really, really, really critical. Our nurses at our clinic do a great job of this, but it's super important to be talking to patients, educating patients really every step of the way because they're at home kind of on their own doing this as opposed to coming in and receiving treatment from us. And patients are often taking many other medications, as you know, whether it's other cancer treatments, whether it's supportive care medications, primary care things. So really, they're on a lot of different drugs. There's a lot of different things we got to look at in managing these patients. So the different types of oral oncolytics out there. So there's 3 broad types. I won't go too far in depth into this, but really it's broken down mostly into cytotoxic chemotherapy, targeted therapies, and hormone therapies. So as we know, cytotoxic chemotherapy works by killing all rapidly dividing cells. There's no target, there's no specificity. It kills anything that grows and divides quickly, whether that's cancer cells, whether that's hair follicles, GI tract, etc. Targeted therapies are really types of treatment that target a specific pathway that we know allows cancer to grow and spread. So we'll talk about a variety of different targets that are out there. This again is super broad. There's so many different targeted therapies out there now, but really main difference is that this is targeting some sort of specific pathway that we know the cancer is using to grow. And then thirdly is hormone therapy. This blocks the production of hormone or how a hormone acts in cancers that are driven by those hormones, things like breast cancer, prostate cancer. So we'll talk some about that as well. So cytotoxic chemotherapy, like we talked about, is just as strong when it's in oral form as it is when it's in IV form. So really super important here to be stressing adherence. We know that the way cytotoxic chemotherapy works, the mechanism of action, you really need to try and keep patients on schedule as much as possible. So stressing adherence, always talking about adherence, are patients having trouble remembering their medications? So those are things that really need to be followed up very closely. Safe handling precautions and exposure to bodily fluids, we will talk about later on in kind of the safe handling precautions section. But with cytotoxic chemotherapy, we know that there are many extra precautions that the patient needs to take, the patient and their household needs to take, etc. And toxicities of cytotoxic chemotherapy, we know bone marrow suppression, often GI related, hair loss. So those are just a few. And then I just listed some examples of oral cancer cytotoxic chemotherapies that you might see. So capecitabine, cyclophosphamide, temozolomide, etoposide, etc. Targeted therapies. So like I said, there are many different targets associated with cancer, and they're not even necessarily, in the same category of types of mutations. So you can have, like with a BRAF mutation in melanoma, it can be really just a point mutation. You can have an overexpression or a fusion. So there's a lot of different targets that have been identified in a variety of different types of cancer. So targeted therapy really is a very broad term. But I put some examples here. These are some really good examples, which we'll go over on the next slide. And this is definitely what kind of triggered the precision medicine movement. So allowing us to really target something that we know is driving a cancer, and really testing people's tumors to essentially find out if they have this specific type of mutation that we can then treat with a certain medication. So more targeted precision approach. Toxicities from these are often more dermatologic. They can cause hepatotoxicity, a variety of different cardiotoxicities, as well as bleeding and clotting, which is why we'll talk about VTE a little bit later on. So this slide I put in here really just as a reference, so that you guys could kind of have something to look at in terms of the different types of targeted therapies out there. So this one in the top left-hand corner, this is talking about the BCR-ABL gene that drives CML. So essentially this rearrangement here that then creates this BCR-ABL fusion protein. We know that imatinib or Gleevec binds to that fusion protein, and that's how imatinib works in CML. This is another example looking at EGFR tyrosine kinase inhibitors. So this is something that binds intracellularly on the EGFR receptor. And as we know, EGFR here, this is looking at EGFR driving lung cancer. So essentially a mutation here, which is an overexpression, allows these pathways to kind of grow and divide uncontrollably and be constitutively active. So we have a variety of targeted therapies that bind here. And then my personal favorite is the MAP kinase pathway. So this is looking at really BRAF and MEK and the role that it plays in metastatic melanoma. So again, very typical tyrosine kinase pathway here, where this being active leads to gene transcription, growth, proliferation, etc. And we have BRAF and MEK inhibitors that target this pathway. And then hormone therapy. So these are hormone-driven cancers, like I said, breast, prostate, ovarian, endometrial. Really the drugs for these cancers block hormone production or the binding of the specific hormone to whatever receptor it normally binds to. So toxicities here, as you can imagine, things more like hot flashes, changes in libido, decrease in bone mineral density, joint pain, etc. So in terms of dosing, I was really just typing out things that I think to talk to a patient about every time I see someone starting on oral chemotherapy. What are the most important things that we need to be talking about? So obviously taking the medication exactly as prescribed. I feel like that sounds kind of obvious, but you would be surprised at how many times those things get confused when people meet 800 providers and they're at a new place and they're very overwhelmed. So take exactly as prescribed and really emphasizing to them that you're relying on them to take their dose appropriately. So it's not like they're coming in to receive their treatment. It's really up to them. So putting that responsibility on the patient. Their timing must be consistent. So they really should be taking it at the same time every day. If it's twice a day, I always say as close to 12 hours apart as you can, and just being consistent with that. How to handle a missed dose or an extra dose. I feel like this is something that should be emphasized. These are things that usually come up after hours when patients don't really know what to do. So the general rule of thumb is if you miss a dose, you skip it and you move on to the next one. Some package labeling does have very specific time frames for if you remember within 6 hours, go ahead and take it or whatever. If it's beyond that, then just move on. But in general, the rule of thumb is don't ever double up or try to make up a dose. Just kind of skip that dose altogether and move on to the next dose. In terms of what to do for an extra dose, I believe I put a phone number a little bit later on. There's an FDA number where you can call, or a poison control line as well. If there's an on-call number and it's after hours, they can always call the provider that way. If it's during hours, recommend calling. If it's something where they think it's life-threatening, they took too much chemotherapy, whatever it is, the recommendation really is if they don't have anyone to talk to or they can't get in touch with anyone, they really should go to the ER. And then dose adjustment for renal or hepatic impairment. So with many oral anti-cancer agents, we know that depending on the patient's renal function or hepatic function, that many drugs are cleared renally and hepatically or metabolized hepatically. So there often are dose adjustments that need to be looked at. In terms of administration, so in general, you should never tell a patient to cut, crush, chew, split, etc. Their oral cancer therapies. There are some exceptions where maybe there is something that comes in a liquid form, but in general, you should be telling patients not to do those things if for some reason they're having trouble swallowing their medication or anything like that, to reach out to you or their provider. Always check if a drug should be taken with or without food. So a little bit later on in the drug interaction section, I have a table, but food can alter the exposure of drugs in many, many ways. And it really is drug dependent. So sometimes the exposure will be increased, sometimes it will decrease the absorption. So it's just something that you have to look at individually. And then in terms of gastric pH, we'll talk again more about this in the drug interaction section, but many drugs, absorption is affected by gastric pH. So if it shouldn't be administered like within a certain number of hours of antacids or anything like that, then that is something that needs to be discussed. And then I put AM or PM on here. There's not many drugs that dictate they have to be at a certain time of day. Oftentimes I just tell patients as long as you're consistent, but there are some things that may be better tolerated if taken at a certain time of the day. So, if someone's having nausea or there's something where you're worried about nausea, might be better to recommend in the evening so that they potentially sleep through it as opposed to just waking up and taking it and then feeling, nauseous during the day. Again, this is really patient specific and kind of patient dependent, but just wanted to kind of put out there the things that you should be discussing with patients. In terms of adherence, so there are many studies out there looking at oral oncology adherence. And as you can imagine, some studies describe rates as low as 20%. And in my mind, what kind of sparked the whole adherence issue and really how important it is in cancer was in CML. So that same example, the BCR-ABL example that we spoke about earlier. So there's many studies out there looking at patient-specific outcomes in terms of mortality, how well patients do is directly linked to adherence. So in CML, major molecular responses and patients' ability to keep those responses is directly correlated with them being adherent with their medication at least 90% of the time or greater. And so there's very specific data out there saying that they have to take this, and be adherent at least 90% of the time for their best outcomes. But there's many, many reasons why patients might be non-adherent. And so I put this slide in here. So there's many, many things obviously involved: social economic issues, health system issues, patient-related issues, complexity of the therapy that they're taking. So there's really so many things that play into this. And I feel like, you as nurses are speaking to patients regularly. Patients really well. If they have something going on at home, if they forget to take their normal blood pressure medicine, whatever it is, really just having a conversation with them and kind of assessing upfront whether you think they're going to need extra support from you or not. And in this day and age, we have some great resources available on smartphones. So most people have smartphones now, and there are many, many apps out there that help with adherence. I took a snapshot of one. It's called MediSafe. A lot of them will text you when you're due for your medications. They have pictures on there, so you know exactly what it is and what time you're taking it. So these can be very, very helpful. There's other things that they can use, like a calendar or a journal or something like that. And then I put manufacturer on here. Some manufacturers actually provide support programs where they can call patients and also provide support as well. In terms of safe handling, so all oral oncology medicines, for the most part, there are some exceptions, but all of them really are considered hazardous in some way, meaning that really no one should be handling them except for the patient, if at all possible, because they can potentially be harmful. So recommending that they wash their hands really well before and after handling. Of course, there's no risk to the patient touching it because they're the ones taking it, but make sure that they wash their hands well before and after. Exposure to bodily fluids. The section is really focused on cytotoxic chemotherapy. That's really where there's the most data, where you should be washing linen separately. If someone ever vomits or has an accident, wearing gloves to clean it. If at all possible, having a designated bathroom or closing the lid to the toilet when you flush. So really the most data for this is towards cytotoxic chemotherapies. And then storage and handling kind of all loops together. So in terms of storage, the recommendation is to keep everything in the original packaging that it comes in. The way that I explain it to people is store things high and dry. So high away from kids, pets, anyone that could potentially get in a hold of it. And then dry, meaning not near a heat source, not near moisture, definitely not in the bathroom where everyone's medicine cabinet is, which doesn't make sense. So high and dry. And then is there a temperature requirement? So some tablets and some medications do have to be stored in the refrigerator versus room temperature. So if you ever have questions, you can always ask your pharmacist or check the package labeling. It is a little weird for pills to be stored in the fridge, but there are those out there. So just checking. In general, the recommendation is to not use a pill box, just to prevent mix up with some other drug. If they absolutely have to, they can use like a separate pill box as long as they keep it somewhere else, keep it separate from everything. But in general, try to keep them and have them keep it in the original packaging. And again, storing away from other family members, medications, etc. In terms of disposal, never, never, never throw oral cancer therapies in the trash or flush them down the toilet. Never. So I have all of my patients bring them back to us because we can dispose of chemotherapy. If they ever have questions, there are 2 DEA national take-back events a year if they don't want to wait until then. There's also an FDA number where you can call and they can provide additional information, or they can call their local law enforcement. I have been told that here in Denver that The Comprehensive Cancer Center Pharmacy at St. Joe's accepts chemotherapy drugs. I have not personally sent anyone there, but that is what I'm told. Drug interactions, I'll try to breeze through a little bit of this. This is definitely more pharmacy heavy, but really the most important thing to know is that patients on oral oncology medicines should be having MedRecs performed regularly. That includes all over-the-counter medications, herbal supplements. You need to advise them, really they should be carrying a current medication list and notifying us as well as their other providers if they are starting anything new. And really this is where you guys come in, is educating patients on the potential, as long as they know and understand, like, hey, if I start something new, if I go to urgent care, if I want to start an herbal supplement, whatever it is, that they know that they need to let us know prior to doing so. The reason for that is many oral oncology drugs are metabolized by CYP enzymes. There's a variety of different drug interactions that have been reported. If something is an inhibitor or an inducer of said enzymes, then that obviously affects the level of the drug in the patient's body. So if it's being metabolized more quickly, the level of drug in their body is lower than it should be and could potentially reduce therapeutic effect. If the enzyme is not metabolizing the drug as quickly and it's building up in the patient's body, that of course puts them at a potential increased risk for toxicity. Some medications do have specific dose modifications in the labeling. So if you're on a strong CYP3A4 inhibitor, reduce the dose by this much. Not all medications have that, but some of them do. And then gastric pH, there are many, many different drugs out there that have to be separated by antacids, are not allowed to be taken with things such as PPIs. So again, if you ever have questions, you can ask a pharmacist or check a drug interaction database, but just know that there are many drug interactions in terms of certain drugs need a certain gastric pH in order to absorb. QT prolongation, we're always thinking about this. Many oral oncology drugs are associated with QT prolongation. So again, another important reason to be doing MedRec. And then food interactions, not just whether or not it should be taken with food, but also we know that grapefruit has drug interaction. It's a CYP3A4 inhibitor. And so that's really the most common thing that comes up. I put these numbers in here really just as a reference for you guys and kind of as just a cool study that I found. It's a comprehensive review of oral chemotherapy drug interactions. They looked at 58 different package inserts, and I basically just wrote down here what they found. So the CYP450 enzymes were really the most predominant substrates that were found in 41 of the meds. The effect on warfarin absorption I found pretty interesting. So 16 of the 58 drugs had some sort of effect on warfarin. 14 were associated with QT prolongation. 9 were had their absorption affected by acid suppression. 3 had interactions specifically with calcium-containing supplements, Tums, calcium, vitamin D, etc. 9 of them have pH-dependent absorption, and 15 had a clinically significant DDI with grapefruit. So really just kind of as a reference so you know to be looking out for these things. And then I just put this in here really just to have you guys have it as a reference so you could kind of see. And then I put the link in there as well. Obviously, this table is much longer than this. In terms of access and reimbursement, I made this word cloud and it was like stressing me out even making it, because every time I think about what our patients go through, it is very overwhelming. And so these were just like a handful of words that I thought of right off the bat when I think of access and reimbursement to oral chemotherapy drugs. Co-insurances, what's my copay? Am I in network? Do I have a deductible? Oh, I have Medicare. I didn't know I needed Medicare Part D. So I mean, there's so many things that play into this. And we know for a fact that financial toxicity is by far one of the most significant sources of stress for our patients, for their families and caregivers, for a variety of different reasons. They have to drive to and from the hospital. They have to take time off from work. Their spouse has to take time off from work. Their treatment is expensive, whatever it is. So we know that we need to help in whatever way we can when it comes to these drugs. All of these drugs, for the most part, are very expensive. So should always be verifying insured status up front and assessing patients' need for additional help. One thing that comes up a lot is Medicare Part D, like drugs. So prescription drug coverage is covered by Medicare Part D for the most part. There are a few oral chemotherapy drugs that are covered under Part B, like boy. But for the most part, patients need Part D. So that's something to be asking, and that's often a separate card, separate billing information, et cetera. And then for Medicare patients as well, do they have a supplement? If they do have to come in for something, do they have some sort of supplemental coverage that will help with the cost? I'm not sure how much you all get involved in financial assistance. This is really just so you know kind of what's available when patients ask questions, say, hey, my copay is $500. I didn't know it was going to be this much. So that you kind of have a background of what's available and what you can do to help. So drug manufacturers do have a lot of different resources. All of them usually have some sort of copay card for commercially insured patients. So if they have a normal employer insurance like Aetna or Cigna, whatever it is, they can use the copay cards. Some manufacturers will also provide clinics with vouchers or samples to help patients up front. Patient assistance programs are available through manufacturers if you have a patient who has no insurance. So in this case, it would be if a patient has Medicare A and B, but no Medicare Part D. So they don't have any insurance to cover an oral drug. So here you could apply for a patient assistance program. Or if a patient has Part D, but their copay is like $4,000, they're considered underinsured because that's obviously not affordable. So in that sense, they can typically apply for patient assistance programs through the drug manufacturer. The not so great part about these is that federally funded insurance, so anyone who has Medicare or Medicaid cannot apply for manufacturer copay cards. So in that sense, you will have to essentially get financial help from somewhere else. This is usually from private foundations. I've listed a few here that I use very typically. And then I listed needymeds.org. This is a great website for people to use where you just type in the drug name. And if there is anything available, it really pops up there. So that's a good resource. Contraception, this is like my new hot topic when it comes to chemotherapy, as well as oral chemotherapy, because I feel like it is just not talked about enough. And especially in our clinic, we have so many young patients that I feel like this needs to be emphasized more. So we know for a fact that cytotoxic chemotherapy is teratogenic. It increases your risk of infertility in both men and women. Targeted therapy, there really is not as much data. For the most part, what I've found is really just animal studies. So there really are not studies of pregnant women taking specific targeted therapies, really is what it comes down to. So the risk is out there. They say that, you know, it could potentially have a risk, but for the most part, most package labeling cites animal studies. And then hormone therapy, I did find information out there about hormone therapies causing birth defects. Of course, if you're giving someone a bunch of drugs that is essentially inducing early menopause, then that can affect someone's ability to become pregnant. Pregnancy tests really should be done before starting treatment in patients or women who are childbearing age and periodically throughout treatment. And education is super, super, super important because the contraceptive requirement is very different depending on the drug. So always check the time frame. This is listed right in the package labeling. So I put a couple examples here. So for trametinib, women are required to use an effective form of contraception during treatment and for at least 4 months after the last dose. So that's a long time for women to have to be reminded, okay, 4 months after the last dose, I cannot become pregnant. Whereas sunitinib, it's during treatment and for 4 weeks after the last dose. So always check. Many targeted therapies do not have clear data on whether or not they are secreted into semen or vaginal fluids. So we know that chemotherapy can be secreted into bodily fluids. We don't know as much about targeted therapies. And so really the guidance should, in my opinion, err on the side of caution, but we really just don't know. And then always, always, always check drug interactions. So many oral contraceptives are substrates of CYP3A4. So checking if the oral chemotherapy that they're going on can potentially make that birth control less effective. And then the last thing I'm going to talk about is VTE and cancer patients. So we know that in general, cancer is a hypercoagulable state. Our patients are at higher risk for clotting, really at baseline compared to a normal person who does not have cancer. The incidence rate can be reported anywhere from 4 to 20%. I saw one study that listed 5 to 25%. It's kind of somewhere in that range, but that's really high. That really is dependent on a variety of different things, such as the type of tumor that it is, the stage. So obviously metastatic patients are at highest risk, and then patient-specific factors as well. In terms of treatment, so I listed a few things here that automatically put patients at higher risk. So we know SERMs, or selective estrogen receptor modulators, so those are tamoxifen and raloxifene. Those increase your risk for clotting, as well as IMiDs. So things like thalidomide or lenalidomide, those are probably the highest risk. I saw rates up to like 25% of patients taking IMiDs. And then VEGF inhibitors. So we know any drug that affects VEGF increases the risk for bleeding, but also increases the risk for clotting. So when you're seeing these patients who are starting an oral chemotherapy agent and you say, okay, my patient's starting sunitinib, or my patient is starting tamoxifen, or whatever it is, if you know that they are already at an increased risk for having a blood clot, I feel like education up front on the signs and symptoms of VTE should be done. And so those are things like swelling, redness, pain, warmth, for a DBT, for PE, things like shortness of breath, racing heart, chest pain, etc. So I feel like this really should be incorporated into upfront education for our patients going on oral chemotherapies. So in general, new oral oncolytics are constantly being approved. We do have good options for patients who maybe have travel restraints or can't make it to the hospital. But also on the flip side, we are placing the responsibility on our patients to take their medicine every day, take it appropriately, take it with or without food, depending on what it is. Oral does not necessarily mean less toxic or less effective. And less frequent monitoring at the hospital means increased education. So nursing roles are so crucial when it comes to these patients, because you guys are really the first patients that are going to hear these issues, hear these questions. You are the ones that are talking to the patients the most and are really on the front lines. And so constantly looking out for these things is crucial to managing these patients on oral oncolytics. And with that, I will take any questions. I put my email address there. If something comes up after the talk and you have a question or just want to reach out, feel free to email me at any time. Thanks.